rettsyndrome.org virtual conference week. We've had some wonderful sessions this week, and I'm very excited about our topic today with Dr. Tim Fema. Dr. Tim Fema, this is Paige Nuez. I'm with rettsyndrome.org, and on behalf of our board of directors and our entire team at rettsyndrome.org, we're so pleased to have you join us today and this entire week for our session of free webinars to help educate you and deepen your knowledge of Rett syndrome research and care practices. For those of you who are joining us for your first webinar this week, I want to go over some of the technology so that you'll know what you can do during our session. The audio feed is open only for our presenters, so you don't have to worry about background noise interfering with the presentation. And if you look to the upper right corner of your screen, you'll see a control panel window. And we invite you to submit your questions for Dr. Fema in that question box. Put your questions in at any time throughout the presentation, and we will hold and answer them at the end. If we don't get to your question during today's webinar, we'll work with Dr. Fema to get your answers through email afterwards. So don't worry if we don't get to you today. And if that control panel window is distracting to you, you can click on the small orange box with a white arrow to minimize that window, and then click on it again to expand it if you want to submit a question. We don't want you to worry about taking notes during the presentation today. The session is being recorded, and you'll receive a link to the recording by email. So that way you can just spend your time focusing and thinking about the content that we're going to hear today. I would like to introduce our speaker. Dr. Tim Fema is the co-director of the Rett Clinic at Gillette Children's Hospital with Dr. Art Beising. They've had the Rett Clinic for 6 years now. He knows many of you who are attending today, and I'm sure we'll meet many of you more in the future. Dr. Fema is a pediatric neurologist at Gillette Children's Specialty Healthcare Hospital, and his interests include following NICU babies and seeing patients with epilepsy, metabolic disorders, and movement disorders. Quite a nice spectrum of interests. After receiving his medical degree from the University of Wisconsin Medical School, Dr. Fema completed a pediatrics residency at Penn State, Hershey Medical Center in Hershey, Pennsylvania, and he then completed a pediatric neurology residency and fellowship at the University of Washington in Seattle. He has a professional membership with the Child Neurology Society and the American Academy of Neurology. So not only is he well-grounded in Rett syndrome, but in quite a few specialties. And he is going to help us understand today autonomic dysfunction in Rett syndrome, which is an often slippery, difficult topic to understand, but very important for all of us with children with Rett syndrome. So what I'd like to do is turn over our next hour to Dr. Fema, and again, go ahead and submit your questions in the text box, and we'll get to them at the end of the talk.
You can hear me okay?
Very great.
Okay, great. So thank you, Paige, for that wonderful introduction, and it's nice to meet everybody virtually, but and certainly we don't have quite the depth of experience that some of the other clinics do, but we have a large population here that has been wonderful to get to know, and certainly is teaching me often more than I'm teaching them. Specifically for this topic, I was going to talk about autonomic dysfunction, and it's a deep, deep topic that they write hundreds of pages, hundreds of page books about, so I'll try to give everybody a brief introduction, and it's something that I think impacts just about every patient I see with Rett syndrome to varying degrees. When we talk about Rett, in most talks we do, we usually have a disclosure page first, and I have nothing to disclose. I don't receive any money from anybody. I do have an unpaid intern that helps me with most of my talks, and I can't get her away from me when I do give my talks because she has to be by daddy all the time, which drives me a little crazy, but I love her dearly. I'd like to start this talk more specifically when talking about Rett syndrome with the patient. And I suspect that this story won't be unfamiliar to many that I speak to. And one of the patients whom I follow is a 12-year-old girl with Rett syndrome, and I should mention that she also has epilepsy, she also has constipation, she also has sleep issues, she also has learning problems, but one of the most distressing things to the family was the daily episodes where she would seem very agitated, breathe very vigorously, her eyes would, quote, move all over, she would become flushed, and she would seem very confused. At times during these spells she would scream, and I mean not just scream, I mean blood-curdling screams, and seem as though she was just frightened, upset, scared, and just, it was certainly very distressing to the family, and I saw a spell too, and it was very distressing to watch. Keeping that patient in mind, I am going to circle back to talk about that patient later in the talk, but before we talk about this patient and kind of what the workup involved, which I'll discuss briefly at the end, I'd like to kind of start laying the groundwork so that we can talk a little bit more in depth about this patient specifically. And I like simple slides and I like simple questions, so I'd like to try to discuss a couple things, including what is autonomic dysfunction, what is the autonomic nervous system before even that, is autonomic dysfunction a problem in Rett? Hint, the answer is yes, and is workup available for this to quantify it, and what treatment exists. I think moving on to what the autonomic nervous system is to start with, quite simply, the autonomic refers to the self-driven or automatic part of the nervous system. I should warn you, I will have some busy slides. I try to keep things simple, but there are some things that defy simplification at times. The autonomic nervous system does really not originate from one specific area of the brain. The hypothalamus and the amygdala are very important parts, but there's connections to the frontal lobes, to the midbrain, where some of the, and actually the medulla as well, where some of the breathing centers are, and truly the connections from the brain then proceed to every part of the body. Trying to keep things simple yet a bit before we get to a busy slide. The autonomic nervous system really, the automatic or subconscious part of the nervous system, this autonomic nervous system, really helps to try to maintain equilibrium. There are portions of this nervous system which increase our blood pressure when we get exercise. There's portions that decrease our blood pressure when we rest, because we don't need to be pumping blood to all our muscles and all of the organs regularly. The system very carefully regulates the blood flow to our liver, to our heart, to our kidneys, to just about everything. And there are two divisions to this part of the brain and spinal cord that really seem to impact different organs and body differently. There's the sympathetic, which if we were to just really briefly and try to summarize it simply, it kind of promotes the fight or flight. You exercise, we all know what it's like to have our adrenaline pumping, and that's sort of one extreme of the sympathetic nervous system. There's the parasympathetic, which seems to be more predominant when we're resting. And this is the rest and digest. Sometimes people say eat and excrete. And these are things which we don't think about every day, which happen automatically. And to really complicate things, and again, in some ways the autonomic nervous system defies simplification, the impact of the sympathetic versus the parasympathetic is very broad all over the body. Not to get overly into one religion, but I think of it as the yin and yang. It's kind of the balance of the two which makes us functional and makes us happy. On the one side, for example, if we focus on the parotid glands, the submandibular glands, one side might decrease salivation, one side might increase salivation. And so drooling is something that we see when there's autonomic dysfunction. In truth, both sides can increase the salivation a bit, but we'll just leave it at that. Other thing that many of us are familiar with is the heart rate. And I will delve more deeply into this matter a little bit later in the talk, because, again, in the one extreme, the sympathetic part of the nervous system increases your heart rate as you get ready to exercise, flee from a predator. There's not too many predators nowadays, thankfully, in our world, versus the other side, the parasympathetic, which actually calms the heart. You don't need a heart rate of 200 when you're resting comfortably on a couch or a chair, hopefully. And one other thing I'd like to bring attention to as well is the adrenal medulla, right down here. Not overly important, but it is where some of the epinephrine, the adrenaline, is made. And I do wonder with some of these spells, mentioning the 12-year-old patient I started talking about with this talk, sometimes dysregulation of the adrenaline or the epinephrine that's released can lead to things like panic attacks. And sometimes there can be dysregulation of when that panic attack or that fight or flight response gets triggered when the hormones get released because the sympathetic nervous system influences that. But rather than go through all the connections and the anatomy with the brain up here, the spinal cord here, I think another thing to talk about would be what autonomic dysfunction might look like. I do apologize. The one last circle I wanted to emphasize as well was the stomach and the bowels. One side will kind of shut down your stomach and your intestines so they slow it down so you can shunt blood to your muscles for that kind of fight or flight with the sympathetic. The other side, the parasympathetic, does eat and excrete. I bring this up specifically because we see abnormalities with this in old people with diabetes, for example. They have gastroparesis. Gastro is stomach, paresis means slow movement, so they have delayed emptying of their stomach, and that's something we see often, I feel, in many girls with Rett, as well as slowed emptying of the intestines and colon, which leads to rather significant constipation at times. To think about what autonomic dysfunction might look like, because there's such broad distribution of connections, the truth of the matter is that the symptoms can be, well, really just about anything. And by that, you can have, this is an excellent paper that was written in Pediatrics just about 9 years ago, where they talk about this kind of yin and yang, these extreme swings of, with the blood pressure, you can see high blood pressure, low blood pressure. With the GI symptoms, like we talked about briefly, you can see bowel dysmotility, reflux, recurrent vomiting, bloating, which is a little tough too because sometimes girls with Rett do breathe and they air swallow a lot, so the bloating can be from other reasons. But I should have mentioned that sometimes that the respiratory system can be impacted as well by the autonomic nervous system. Excuse me for 1 second. The things to emphasize here, which I think are particularly relevant to Rett parents, beyond what we talked about briefly before with the cardiac, with the GI system, and with the drooling, are respiratory, which certainly it's hard for me to come up with a rate, but almost every girl I see with Rett either has some component of breath holding, air swallowing, hyperventilation, or kind of a mix of all of those at varying times. And certainly there can be some apneas triggered by this. This gets a bit more complicated too because, again, many of the issues covered by the autonomic nervous system can be covered by other portions of the nervous system as well. But certainly the autonomic nervous system plays a role in some of the apneas we see. I'd also like to mention this as well, which is that the autonomic nervous system is near one of the two main structures is the hypothalamus. And without getting into too much detail, the hypothalamus also is significantly important in regulating sleep. There's input from the back of our eyes with seeing daylight, but you can have autonomic dysfunction that significantly impacts sleep as well. One of the screening tools, because it's so hard to show, for example, the picture that I showed with all the anatomy versus this picture, when we've actually developed a questionnaire that we use often here. And I'm not trying to toot Gillette's horn. It is my home where I work, but we tend to ask people a lot about some of the symptomatology in the sense that you have trouble with cold hands or feet, the hands or feet reddish or bluish in color, or there are other portions of the body that are discolored. Is there trouble with decreased or excessive sweating? Pupils that seem large, that's something we hear very commonly. It doesn't typically cause distress, but kids could be having that in association with difficulty with focusing visually. Flushing goes again to some of the skin color changes, slowed emptying of feedings, that gastroparesis, that stomach paralysis, the stomach slow emptying, or episodes of fast heart rate that don't really link with exercise. we must talk about blood pressure that's high or low when it should be high or low. We're really focused on Rett today, but there's lots of more common times when people might have some autonomic dysregulation, and one specifically that many of us have some contact with is what we call syncope, passing out episodes. I just bring this up. It's an older paper by Wouter Wheeling's group out of Europe, as well as others from the Lancet, but it shows, for example, the heart rate. Our heart rate's not constant. It changes from second to second, minute to minute, and it changes. Our blood pressure, this is the blood pressure, up high is systolic, the high number that you get. If you have 120/80, this would be the 120. Down low is the low number. This would be like the 80 or the 50. And we do see people who do not have Rett who, when they change position, lying down, standing up, sitting down, where they don't adjust like they should. And when your body doesn't adjust like it should, when the autonomic nervous system doesn't react like it should, then you can pass out. This can happen for many reasons. And it can happen just people who are otherwise have no other issues but just have pure autonomic failure. I've seen people that can only lie in bed all day and can't even really sit up despite multiple medications. And it's rare, thankfully, and I'm glad not to see that because it's very sad to see. Another thing we talk about a lot, specifically with Rett, is we worry a lot about the cardiac issues. And I mentioned that before briefly, and I'll mention it more in depth now. We talk a lot about long QT syndrome. With the heart rate, there is a way in which the electrical signals that cause heart contraction are started up in the apex of the heart and are propagated down through the heart, sort of like signals traveling along a wire. Sometimes if the interval, this is P, this is a Q, R, S, T wave, if the interval gets long in the QT interval, this is normal and this is abnormal, if we use an example just arbitrarily, because we could get into numbers, but I won't. When this interval gets longer and you do develop prolonged QT, there can be concerns that the heart may spontaneously fire and cause rhythms that can be life-threatening. Ventricular tachycardia, other forms where they can hurt you real quick. They're called non-perfusing rhythms because your heart doesn't act like the pump it should be. It's kind of shocked. It doesn't really pump blood, and that can lead to very significant and dire consequences. This is something one of the main reasons why we do EKGs on a regular basis. We think that it definitely is probably more common than we realize, and we're still learning how much we should surveillance this, but I think a lot of us who deal with Rett are very scared of this because we've all had patients who probably unexpectedly passed, and we do wonder a lot if this is an issue. We also worry about this with all kinds of other genetic conditions as well. Certainly medications can induce this as well, so we need to be very mindful of that. If we try to get away from the abstract of what is autonomic dysfunction, what might autonomic dysfunction look like, and we begin to focus more on is autonomic dysfunction a problem in Rett specifically? And the answer is yes. The diagnostic criteria, even in advance of the genetic confirmation tools, and certainly we do have older Rett patients here, in their 30s and even 40s, who do not have genetically confirmed Rett. The observational criteria for Rett that are long-standing included several autonomic issues, if you think about it, which include peripheral vasomotor disturbances, as well as small cold hands and feet, as well as breathing disturbances while awake. Again, all of these can have direct impact as a result of autonomic dysfunction. Beyond that, some of the research we've done here, we just published this paper this year, we started to do thermal imaging to try to quantify some of these things. For example, this is thermal imaging from our paper, and this is a young girl with Rett who the temperature key over here is not completely visible, but this is 89 degrees Fahrenheit. This is 72 degrees Fahrenheit. So darker means colder, brighter means warmer. In one specific child who has Rett, you could clinically see this in the clinic, but we're also trying to figure out can we quantify this even more. I mean, the gold standard is we'd like to try to alleviate stress, and also hopefully find an intervention that helps, prove that this helps, oftentimes with research we need to find clinical markers that we can assess as we give medications or new treatments to say, does the treatment work? So we continue to work here more in clinical-based research to see if we can find changes we can intervene upon and prove, are we doing a good job or not? I think we need to have checks and balances with that, and if it makes us feel better but it doesn't change anything for the patient, then it's really not worth pursuing. And the exact rates of dysfunction in the autonomic nervous system with Rett syndrome are sometimes difficult to establish. When we focus more in, let's say, specifically on some of the cardiac issues, there have been some papers that have pooled multiple studies. And a paper from Icampa and Guideri a while back was concerned that maybe as many as 30 to 55% of Rett cases had a prolonged QT interval. Again, this was pooling several studies, small numbers each, but it does shine a very clear light on the fact that this is a significant concern we need to be mindful of because cardiac stuff can hurt you quick. And I don't mean to be too colloquial about the way I say that. Delving into the next topic a bit, is there workup available for autonomic dysfunction? I mean, it's one thing to have a report of, the feet are discolored. The heart rate seems to be abnormal at times. We can do simple interventions such as just taking the heart rate, but it's always so tough in some of the research we've done to know what the right interval is. Should we watch the heart rate for an hour? Should we watch the heart rate for 3 hours, for 24 hours? And the answer is not entirely clear with many of these things. There are some tests out there which actually can measure some of your autonomic function. For example, we don't do this routinely where we're at here, but it's available locally, where we can do quantitative pseudomotor reflex testing. Fancy term for it measures, are you sweating like you should sweat in regard to some chemical stimulus. So we can actually prove that, again, that the response to heat, that the response to certain chemicals, that you're not sweating like you should, and there's a problem. There's other tests too, where you actually can look for regional autonomic issues. You can actually look at the thermoregulatory sweat test where people have hyperhidrosis or hyper too much, hydrosis, too much sweating. As you can tell, I teach a medical interpreter class, so I tend to break a lot of the words that I say down into their Latin roots and Greek roots, just because a lot of our terminology, like hyperhidrosis, sounds very fancy, but when you break it down, it just means too much sweating. There are some other things, chemicals you can apply to look at where the sweating is in the body. You can see very abnormal distributions for different people as well. A lot of this has not yet been applied to Rett, but I would be false if I said that we weren't looking into some of these things beyond some of the thermal imaging, which I already showed you. Another thing that's commonly used is tilt table testing. And I showed you that somewhat strange graphic before about the person who had pass-out or syncopal spells. And what we can do is there's a certain way that your body should respond as you go from lying down to standing up. If our body didn't oppose gravity, when you stood up, all your blood would pull, the earth would pull all the blood down to your legs and you pass out. So your body actually subconsciously, unconsciously reacts to your change in position and makes sure that all the blood gets squeezed up to your brain so you don't stand up and all the blood rushes down to your feet. Again, lots of this is just subconscious. And with these tests, they will do things like watch the spread of the blood pressure along with your heart rate, so we can make sure this is more of a normal response if someone got tilted up. In this curve here, this is someone who's truthfully heart rate goes sky high while the blood pressure bottoms out. This is the kind of person that if they got up, they probably would pass out and fall to the ground. Which further complicates matters sometimes because people who pass out can then have reactive low oxygen seizures, but I'll talk a little bit about that too. What I'm not mentioning in the workup is an EEG. And my understanding is that Dr. Tarquinio talked to you a bit about seizures and epilepsy, as well as you received a talk about movement disorders as well. We could abstract from some of this just to say that often working up symptoms in nonverbal children can be one of the most difficult things that we do. These kids will they'll come in with acting strange with spells, and we'll talk about an EEG. We'll talk about blood tests like checking for thyroid dysfunction. We'll check electrolytes to make sure there's not something wrong there. We'll make sure there's no anemia. So when I present some of these really focused tests that deal with autonomic dysfunction, they typically don't happen in isolation. And I will probably circle back to that story of the 12-year-old at the very end. And again, I think that story will ring true with many people. The important thing to talk about as well is not just what the symptoms are and how do we test for it, but beyond the testing, taking a good history for it, but what treatment does exist? Because I think this is a little bit controversial too, because if you talk to, I often say to my patients, if you talk to 5 neurologists, you might get 6 opinions. And I think that my first foundation of management for true autonomic dysfunction, if we've proven that it's not something else, it's not seizures, it's not discomfort or pain response, because these can all look very similar, is that I recommend symptomatic management. I mentioned before that the connections of the autonomic nervous system, we can talk about discrete areas of the brain, but everything plays a role. It means emotions. It means sensations can play a role as well. It gets complicated because tone and movement disorders are the same way. When I sit by the front door of our hospital, I can watch kids who are comfortable in their wheelchair come to the front door and tighten up like a pretzel and twist up because they don't want to be in the hospital, they don't want to be here. And certainly emotions play a role in movement disorders. Emotions also play a role in autonomic dysfunction. And for example, we all know what it's like to be embarrassed and blush. We all know what it's like to be nervous and get gassy. So we all have some autonomic peculiarities in the way we work as well. You can even think about exercising sometimes and your heart rate will speed up because the brain and the autonomic nervous system aren't discrete. They're engaged and they're completely intertwined. I always recommend symptomatic management at first. So if a child has bad times where their temperature dysregulation or their thermostat seems off because of autonomic dysfunction, I recommend blankets, extra clothing to the body, parts of the body that are too cold. The triggers can be emotional. The triggers can also be a bladder and bowel. I think Dr. Motil has certainly been quite familiar with this process, as have many of the other Rett providers, where we really have to really pay close attention to the bowel health and bowel function, because when the bowels aren't going well, or the bladder is backing up and not emptying appropriately, that can trigger lots of stuff between seizures, movements, and autonomic dysfunction. I'd like to tell you that sometimes it's simple, but a lot of times these initial steps will help take away some of the symptomatology overall. A lot of the books talk about, and I've even seen one time where there was what we call a hair tourniquet, where like a girl with long hair had a hair twisted around a great toe, and she was having stiffening, and people had been treating for seizures. And in the same day in the hospital, until we found that little hair tourniquet, and we cut it off, and she just relaxed. We are very aggressive with constipation, as I mentioned, and the other challenge too, besides emotions, besides needing to stool, besides having pain, is infection. So kids can look quite great. They get a cold, they get a flu, they get a pneumonia, and that drives some of these issues crazy as well. Sometimes to the degree where their temperature gets so dysregulated. We have one patient who does not have Rett in our practice, but has rather significant cerebral palsy, and every time he gets an infection, his dystonia gets so bad, he'll drive us to fevers up to 103, 104. And we've actually had to sedate him before just to keep him calm until he heals from the infections, because when your fever gets high for a prolonged time, you can have other strange things that happen, like muscle breakdown. The muscle enzymes clog your kidneys, and I'm not going to talk about that because that's a whole different talk for a different time. Thankfully, that's rare. If the symptomatic treatment or kind of more conservative treatments do not work, there are meds. And I could go through each med and I can go through each side effect, but I would be honest to say that I'm sure that families have talked online and they see that different doctors do very different things. Let me also mention that just to confuse everybody in medicine, they've given every med 2 names. It drives me crazy. drives families crazy. We have what is usually the chemical name, cyproheptadine, and the trade name that the drug companies spend lots of money researching and making sure they sound nice. Diazepam is Valium. Clonidine is Catapress. Morphine, well, it's been around so long it doesn't really have a trade name so much anymore that we use. We just call it morphine. Topiramate is Topamax. Tylenol is acetaminophen. Ibuprofen is Motrin. And Aleve is naproxen, and it's just the way it is. There's different medications that we tend to use for different considerations. If I'm seeing someone who I feel has a lot of GI issues, maybe has some temperature dysregulation as well as rather significant constipation, I tend to use more cyproheptadine or Periactin. That seems to improve bowel motility and also can help with some of the temperature instability as well. There's a little child I care for from North Dakota who would ride the bus, couldn't control the temperatures well. Every day they would get to school, they'd be a fever of 103, and they'd be sent home every day for an infection. It wasn't an infection, it was temperature instability. Conservative measures didn't work, and cyproheptadine helped keep the temperature regulated better. There's bromocriptine. I don't use a whole lot. It's a medication they still use sometimes for also, well, Parkinson's disease, but it can be works in the dopamine system and can help with temperature dysregulation. Not so much with GI help that I've seen. I work with people that love gabapentin for autonomic dysfunction. I also work with people that hate gabapentin for autonomic dysfunction. We've seen a couple kids who seem to be a lot better on it. I've seen 2 kids who tried gabapentin for autonomic dysfunction, and instead they got significantly hypothermic, dropping their temperature to 92, 93 degrees, and I stopped the gabapentin and it stopped. So I think it's a rare side effect, but I've seen it a few times. Valium I tend to use more for emergencies. And it's good, just makes kids tired, and you know, I want children to be awake and not suffering, and sometimes Valium is a good rescue med, like if we have a bad infection day, to give Valium to get us through till the cold's gone, but I don't always like to use it long term. Sometimes I do. Clonidine is a blood pressure medication as well. It tends to work more for the kids who really get agitated and sometimes may have a little bit of dystonia along with their autonomic dysfunction. I don't mean to confuse this, but again, autonomic nervous system is tied into everything. There's a new term for a condition called PAID, P-A-I-D, paroxysmal autonomic instability and dystonia. This autonomic dysfunction can lead into dystonia and cause people to twist quite a bit. Clonidine is something we use for people who have autonomic dysfunction that then blends into bad dystonia. Morphine I use more for just dire straits. Topamax I've used rarely here and there. It's not always my go-to medication. There has been some literature about Topamax being beneficial in Rett for some of the breathing issues as well. And deep sedation, only in extreme cases. We have kids who get a minor infection, as I mentioned before, and perhaps once or twice per year we will bring kids in and they are so febrile, so uncomfortable, and it blends into some of that dystonia, like I mentioned, with the PAID syndrome, paroxysmal autonomic instability and dystonia, that we've actually had to sedate them until we get them to a healthy place, because they just simply break down their muscle, they just get mild kidney failure, just scary stuff I'm not going to dig into. But what does this look like for some of the patients that we see? And this is taken verbatim from a letter that I dictated for a family with some of their home nursing care to help them deal with some of the autonomic bouts that their child was having. And I changed the name, obviously. The name is not Pat. For example, one of my patients with Rett who was having severe autonomic symptoms, we said that if Pat has a heart rate greater than equal to 120 beats per minute, an increased respiratory rate, or flushing of the face for 10 to 15 minutes, they should begin to assess for autonomic triggers or discomfort. I then coach the family to try to remove tight clothing, check to make sure they didn't stool, check to make sure they don't have to pee, check to make sure there's anything they can identify. Maybe there's another child's toy underneath their seat on their chair that was tucked in there because it was a special present. Sometimes if these symptoms continue for 20 minutes and it's causing distress, we here have arbitrarily sometimes decided that they should have at least 3 of 5 signs. Now, the heart rate that a 2-year-old should have is not the same as the heart rate a 12-year-old or a 20-year-old should have. So these numbers aren't written in stone. They are dependent on age and developmental status. For this patient in particular, who is in the teenage years, we know from monitoring them that their heart rate typically ran in the 70s to 80s. But they would have these times where they would be breathing 35 times per minute, their heart would be 200, their blood pressure is systolic, that higher number, if you have a 120/80 blood pressure, they'd be up near 180. They would have facial and chest flushing. They would have just excessive sweating, the kind that parents say, you know, I checked them 5 minutes later and it looks like I dipped them in a pool. If we saw some of those for 20 minutes, then we would begin to sometimes medicate. And for this patient in particular, even though it's not my favorite medication, we would give bromocriptine, a low dose, and then we would consider repeating it every 6 hours. If this didn't abate symptoms in 20 minutes, and I should mention that this patient in particular had a G-tube, so when you give meds in the gut, you've got to give enough time to make sure it gets absorbed, and this was enough time for this individual. And if it continued, we would give morphine or clonidine. Pathways like this often aren't devised to this degree up front. By this point, we've usually trialed different medications, so we know sort of what emergency meds work, which meds don't work quite as well, and so sometimes we get hints of kind of which direction to go in which direction to really steer the medication ship. No parent wants to give their kids meds. However, some of these kids, when they suffer extremely conservative measures don't work. I'm guessing many parents who are listening have seen their kids where they're tight, they're flushed, they're uncomfortable, screaming for maybe an hour to 2 hours or longer at times. If I may go back to the patient that I started the talk with. So with this 12-year-old girl with Rett, who had these spells where she was agitated, and to be honest, the parents said they just couldn't take it anymore because she just looked so in distress, and she could scream. I mean, blood-curdling scream. She also had significant hyperventilation, so she would really breathe hard during these spells, and eventually we tried low-dose Topamax. And with that, she went from several spells a day to where, and that may have lasted an hour or two, a few spells a week. And the stress level in the home got better, the patient became more comfortable, and it was great. I will say, with this particular patient, it's tough. It's tough to tell movement disorders from seizures. She had an EEG. We captured the spells on the EEG, thankfully, so we knew they weren't seizures. We saw this, we were able to assess her during these spells in the hospital, and I tried, it seemed as though before she really would seem to move all over, and she even seemed a bit dystonic or tight, it seemed as though you could see the autonomic symptoms, the skin changing, the hyperventilation changing, even in advance of some of the twisting or really tightening up movements. And so the Topamax was significantly helpful for her and helped distress her family significantly as well. And with that, this is a huge topic, and I'm not going to say much more because I think that I want to leave room for questions appropriately so. And I think with that, what I might do is open the floor for questions. This is from an annual festival that happens by my house, and they were offering a free didgeridoo into a funnel that went to kids' headphones to help calm them. I've never seen that before. I was fascinated by it, and I still am. I thought that was very fun to watch. But anyways, with that, I'll open the floor for questions if anybody has them, and I hope I didn't waste anybody's time.
Great. Thank you, Dr. Freeman. That was a phenomenal presentation, packed with a ton of information. Thank you so very much. We have quite a few questions in the queue, so thank you for pausing and allowing for us to get to those. Some of those you answered in your presentation, but might bear repeating. So if you don't mind, let me kind of just take them in order that they've come in.
Sure.
The first one that we have is from a parent with an adult child with Rett syndrome. She's 35 years old, and she's always had abnormal breathing and breath holding, but no hyperventilation. And lately, they've been seeing her blood O2 levels jump all over from low 80s to high 90s, and the pulse ox readings are also inconsistent. And her question is if this is normal for girls and women with Rett, or if, as some are suggesting, should they be thinking that it's possibly COPD and consider, starting to have oxygen around and, inhalers, albuterol. Is this a true lung disease? Is it autonomic dysfunction? How would they determine that?
That's a real tough one. So the oxygen bouncing all over is not the biggest concern. For me, the biggest concern would be carbon dioxide retention, if they're really holding their breath. With carbon dioxide retention, kids can get clubbing of their digits where they kind of have this rounded tip. But oftentimes, this isn't really a harmful or overly concerning issue. And the pulse oximetry is tough. Oftentimes in the hospital, I turn the pulse ox off because the nurse is calling every 2 minutes because girls with Rett breathe uniquely. Let me shut that down real quick because I want to just stop these dinging from happening here. Sorry. But let me get rid of that. Sorry. I think a lot of times the best way to really figure out if it's COPD, which is going to be tough in some of the Rett adults that I see, is that we typically decide COPD based upon some of the pulmonary function testing, which is tough because there's a volitional component. You need to blow hard, you need to breathe hard. I personally haven't seen many patients with COPD in adults. COPD patients can't breathe deeply and well, so sometimes they do retain CO2 as well. So they might be suggesting that it's a carbon dioxide retention, but I wouldn't suspect that the patient has a COPD per se. It's easier to treat hyperventilation than it is hypoventilation, or hyper, too much breathing, rather than hypo, too little breathing. There are some meds like caffeine that can stimulate it, but it's a tough thing to treat. But I would probably see a pulmonologist if you have really big questions about that.
Okay. Another question that kind of follows on what specialists to see and when is a good question. Who does autonomic dysfunction assessments? Like, who should the average family living in the average town go to get an autonomic dysfunction assessment done?
At this point in Rett, I think we're more reliant on clinical history than we are the actual testing. Because when I bring up some of those tests, I bring it up because it's a matter of personal research interest for me. But a lot of that stuff is normalized, and the normative data is for adults. We've had some of our girls, none of our boys, because there's a few of them, but go for autonomic testing too, and the results that they get are very variable, certainly abnormal, but difficult to interpret a lot of times. It's also tough too because some of those tests I showed, like the tilt table tests, if you put a Rett girl on a table that tilts up kind of like the Dr. Frankenstein table, they get a little stressed sometimes too. Mm-hmm. And it's hard to know if you're just seeing this anxiety or stress response. I mean, that's what we're trying to do with some of the other things like looking at heart rate variability, checking EKGs, and some of the thermal imaging. Right now, I think the most important thing is not so much the testing, is the annual EKG is the most important thing, I think.
Okay. We have a lot of questions on prolonged QT and that EEG. So the question is, or the EKG, I'm sorry, is how often should girls be checked for prolonged QT? And if she does not have long QT, actually, let me try to merge a couple of these questions because they're very similar theme. Yeah, so what's the regularity of EKG monitoring? How often is it recommended to have it done?
Annual screening.
And if possible, if for someone to still have it without it showing up on EKG, like how long do you test for? Like, so if you do a 20-minute test, a 10-minute test, could it be that they just missed it?
If it's consistently there, they should see it. There's been a couple rare instances where I've seen girls where they have what look like syncopal or passing out episodes with Rett, And then at times I've done some what we call Holter monitoring, where they actually hook the EKG leads up for sometimes a day, 2 days. But they don't analyze the data from minute to minute to look at the QT interval like that. It's pretty good, but really on a screening EKG, you should see it if it's there, and we recommend annual screening.
I agree, and I've heard that for many, and unfortunately, as you said, it's one of those things that can go undetected and is not a one-and-done test. It should be done repeatedly, and if it comes up, it can be treated with medication, so that's reassuring. We have another question about global edema. Could autonomic dysfunction cause global edema, and is there an intervention for that? With autonomic dysregulation, if you have extreme flushing or things like that, you could have extravasation or leaking of fluid into some of the surrounding tissues. Edema, if it's global, it's so tough because there's only so many ways the body can show us something's uniquely functioning. Because there could be lymph issues, there could be issues with heart failure. Certainly can old people who have heart failure and get swollen ankles. If it's a generalized edema, I simply haven't seen that with autonomic dysfunction. It doesn't mean that it couldn't be possible. That's a tough one. I apologize, I don't know much about that. Okay. Let's move on. We have another question. Thank you for trying to answer that. About drug reactions if you have in the person with autonomic dysfunction. So if you have a child with a lot of autonomic dysfunction, can we see unusual sensitivities to drugs like benzodiazepine for respiratory depression? Can they have unusual, things that are supposed to be more sedating actually be more hyperactive? Do you comment on that?
I'm not so sure that it's the autonomic dysfunction that is the issue there. As we're all aware that Rett syndrome is not Rett syndrome, and we're playing with a different computer in every patient I see, meaning computer is the brain. There are always times when I see a paradoxical reaction, meaning the opposite of what I expect. Yes, Valium should make you tired. I see girls with Rett and my other patients with cerebral palsy who take Valium, and one kid was up for 3 days. That may not be so much of an autonomic issue thing as it is just unique impact of the medication in different parts of the brain. Again, the autonomic it's a hazy topic to talk about because it's hard to perfectly put borders on. I think that the medication effect sometimes is more unique brain structure overall than specifically autonomic dysfunction, but I do see drugs that have more autonomic effects sometimes that are unexpected.
Okay. Here's another question from a parent. If you have a child that seems to have pretty severe, recurring, regular autonomic dysfunction, at what point do you decide, you're an experienced parent, you know what's going on, but at what point could this be a real harm, stress situation for her, and the parent should decide to go to the ER or go to urgent care versus trying to manage symptoms at home?
I would probably, in the case-by-case basis, if whoever asked that question, I probably would want to get a direct question about what the symptoms are, because if it's just really significant flushing, well, usually not that big of an issue overall. Could be causing generalized edema, to circle back to our previous question, but if it's there's girls we see who have one red hot ear, and for that I'm not so worried. Now, if you're talking about a kid or an adult who has a temperature of 103, is stiff, is uncomfortable, then a lot of times, and it's recurrent, I mean, in my head I kind of mentally figure I need to have 2 bad spells a month at least before I would even consider treating, because I don't think med is the cure for everything. I prefer not to treat, but if they're distressed, if they've been seeking even urgent care or emergency room, that might be a time to think about some of these autonomic stabilizing medications. I would probably want to know more symptoms because, again, I'm sorry for being preachy to the choir here, but every girl's different. There's no two that are alike, so I tend to really listen closely and act appropriately depending on the patient.
Mm-hmm. Mm-hmm. Thank you. We have another question about urine retention and bladder release,
okay,
and how to manage that. I hear it talked about a lot on our listservs.
Sure. There are some medications that urology will prescribe that can encourage bladder emptying. Some of the medications like cyproheptadine can help with bowel emptying and also bladder emptying as well. When I hear about bladder emptying, one thing is autonomic imbalance. I also pay close attention when I see girls to see they have a lot of spasticity or high tone, or basically spasticity is jerky reflexes. Sometimes if you see jerky reflexes in the legs, that also can mean that we actually have some muscles that control the exit of our bladder, and they can get kind of jerky and spastic too. You can actually have a spastic sphincter. There's lots of sphincters in the body, one in the bowel and bladder and everywhere, actually in the stomach as well. I tend to take a close history there as well. If there's any spasticity, then I bring urology in to make sure we don't need to relax the muscles that actually empty the bladder. But there are times when we do some other things like, ditropans, I didn't mention because it's autonomic interactive as well, but it actually can help the muscles as well, and it can help with emptying. I would love to tell you that I have the foolproof salvation for every symptom that I see, but I certainly don't, and I don't think any doctor does.
I've heard a lot of parents use the old medicine of put her hand in a glass of warm water while she's home, and sometimes it works. Sometimes these old-fashioned interventions can help do the trick, and sometimes it's more a stronger medical issue. Okay, so I've got a couple questions about breathing issues. One parent asked what your knowledge is of dicipramine. So I know there's a clinical trial going on in Europe, so if you can comment on that. And also if you can comment on the role of serotonin and 5-HT1 in breathing function.
My comment on the serotonin is that it seems like it's dysregulated in the brainstem. There's an excellent paper that was written, I think in 2011, where it was about autonomic dysfunction and Rett syndrome, where they summarized a lot of these things. They were looking into the dopaminergic system, the serotonergic system, comparing some of the rat models to humans, and certainly dicipramine can help with lots of stuff. Can help with bedwetting too, potentially. I think it holds promise. I think when I think about drugs overall, reaching back to our paradoxical response discussion, when we call a medication a success, it tends to help, in a study population, 40 to 50%, maybe 35% of the population that's studied. Not to split hairs, but I think that sometimes the medication holds promise. I hope it helps lots of kids, but the stats are good. But when you have your child, the med's either going to work or it's not. So it's going to be 0 or 100%. So I'm interested to see what the research shows. I hope it helps more than 40, 50%, and we'll see. And I think it definitely plays a role in some of the serotonergic system as well, and it might help.
Okay. Thank you. Thank you. So we've had some cardiac questions, we've had some bladder questions, breathing questions, and we have quite a few questions on sleep.
Okay.
And your thoughts on helping to regulate sleep patterns. This week we don't have a specific talk on sleep. And so if you can help families struggling with that now, we've got families who are describing trouble getting to sleep, trouble staying asleep, trouble just staying up for multiple nights, getting days and nights reversed, and then also issues of children waking up in the middle of the night multiple times as though they've had a night terror or nightmare, with stiff legs, looking around frantically with eyes, and it's not a seizure, not caught as a seizure. So I don't know if you put all of those under sleep issues, but I'm going to and turn them over to you.
Yeah, that's a huge topic too. So, so in regard to the circadian rhythm, circa is around and dian is the day, around the day. So there's animals that are nocturnal. Humans, we tend to be awake in the day and asleep at night, unless you're a teenager, which their rhythm tends to shift, so they want to stay up till 1 a.m. and sleep until 11 a.m., but that's a different discussion. The maturation in the circadian rhythm is certainly abnormal in Rett, and it's different in each kid. I'm sorry to do this to you guys again, but I think that we approach typically is conservative, just like with autonomic, because a lot of times it can be autonomic. We tend to just make sure they go to bed in a dark room at 9 or 10 p.m., or at least an hour before they go to sleep. If we try conservative measures, and we also put barriers in the door because we don't want them to wander for my ambulatory or walking patients that wake up in the night, then we'll keep them in the room and try to see if that works. If that doesn't work, sleep is vital because kids that sleep better learn better, have less seizures, and just function better during the day. So we will use medications to try to entrain sleep. Melatonin release is likely partially regulated by the autonomic nervous system. So a lot of times our first trial is the melatonin, which many have tried. It helps induce sleep, but if you give it at 9, it won't keep you awake at 2. It won't keep you asleep till 2 a.m. So it induces but does not cause sleep maintenance. If we tried melatonin and there's still nighttime arousal or even what looks like night terrors, a lot of times we'll try other meds. Some of the meds we try specifically to try to help entrain a good rhythm, clonazepam, trazodone, clonidine. We all have our favorites. I think that I tend to be more biased towards clonazepam because it lasts longer. It will put people to sleep and maintain their sleep. However, it can have a hangover sleepy effect during the day. Some of our sleep med docs I work with here, they like trazodone more, they like clonidine more. But it's time for a frank discussion for sleep maintenance if there's multiple arousals at night to pick out a med that's going to last the whole night. Autonomic impacts is certainly, but it's not the whole story. I think it also depends on what I use for my meds, depending on if someone has seizures and epilepsy, because when people go to sleep, they don't go to sleep and they don't go to sleep and they're in a deep sleep all night. They tend to kind of go through stages where it's stage 1, 2, 3, 4, and as they change stages, usually when they shift gears, sort of, is when seizures might pop out too. So then I might use a med that, some of the off-balance my seizure med dosing. Like I'll give an extra dose at night to see if I can induce sleep and manage seizures without starting a new med if possible. Tough topic. I do have many patients who we've done everything for, and we're still having them in multiple nighttime arousals, but that's a minority, thankfully.
Good. Good. So working very closely with a neurologist, there's a good chance that you can get a good sleep program going.
Hope so.
But it can take some time. I know that's really debilitating for everybody in the household. Okay, I've got one more question, I think, and then we're going to have to be out of time. And like I said, we'll get the questions over to you so we can get everything answered. And if you don't know the answer to this, that's fine. But as you know, it's a very contemporary topic of the use of medical marijuana, or specifically cannabinoids, in for seizure disorder and epilepsy management. Are you familiar with any discussion about research in this area for managing autonomic dysfunction?
Nothing active right now. We go live here in Minnesota July 1st. I'm certified to prescribe. I'm also the chair of the Epilepsy Foundation of Minnesota board. So right now I'm busy with quotes when I'm not speaking to you about medical marijuana, because any parent that's seen their kid go through 8 to 10 med trials where they're poisoned and look sick and can't lift their head up, I figure why not. I also don't think it's the miracle that everybody hopes for. Might it help autonomic dysfunction? I'm not sure we're aware of all the targets of medical cannabinoids at this point. Certainly the medication can have impact if you do try it. I haven't tried it yet specifically for autonomic dysfunction, but it can have impact. Cannabinoids can increase on-field or clobazam levels. It also can decrease dilantin or phenytoin levels, so we need to be careful of the multiple drugs mixed together. But here's my observation. I'm going to probably be certifying some Rett girls very soon so they can have access to medical cannabinoids, and I'm actually interested to take the history and the follow-up to see if it's helped their autonomic dysfunction.
Well, thank you very much.
Thank
I
you.
appreciate your honesty on that. In closing, I'd love to give you an opportunity to tell us how, if families would like to visit you at your clinic, make an appointment in Minnesota, what days of the week are your clinic, and I know we have you listed on rettsyndrome.org under For Families Clinics, but tell us how families can get a hold of you.
You know, we do actually have a web presence with our Rett clinic, and I apologize. I should have had that on my slide. That was really bad marketing of me. But I don't think about that stuff because I'm salaried. I don't make money out of patients I see. But you know, there's the website. We have a Rett syndrome website, and Latasia Erickson is our main nurse. And if you call our phone tree and talk about Nurse Erickson, most people can get you to her.
Great, great. Thank you. Well, thank you for everything that you do for our families and your continued interest. It gives us a lot of hope, knowing that you've taken active interest in this really tough topic for us. We struggle with it every day, and I know we didn't get all of the questions answered as promised, though. We'll do that and get these out, and hopefully this will just be one of many webinars you can do with us, and we can continue down the journey together on this topic. So thank you very much, Dr. Fema. Thank you to all of our attendees for sticking with us today, and I hope that what you've learned has helped you and given you some pathways and some new directions of thinking about how to take care of some of the challenging issues that we have with our kids. It's been a great pleasure for us to bring this webinar to you today. Thanks to our sponsors, Tobii, Dynavox, and Ameripride. We have quite a few additional sessions happening this week. Visit our website and you'll see all of the topics. Please register. And a reminder that this one is recorded, and we'll get you a copy so that a lot of the information that were on Dr. Fema's slides you can go back and reference. Thank you again, everybody. This now concludes our webinar on autonomic dysfunction and Rett syndrome. Thank you, Dr. Fema. Have a great afternoon or evening, everybody.
Thanks so much.